Hi everyone, there's still a few people coming in, so we'll probably start around 5 past. Hi everyone, welcome to our PSA session 4 with me and Yi. We're today going to be covering the calculations and data interpretation sections. it might just be useful to grab a calculator if you haven't got one already, because we'll go through the calculation section first and then the data interpretation section a little bit later. We'll try and keep an eye on the chat as we go along, but if not, we'll answer all of your questions at the end.
And for those of us who couldn't make it today and are joining virtually, we welcome you to today's lecture as well.
Great, so just to start off with, this is the exam structure of the PSA. If you've been to any of our other sessions, you probably will have seen this before. It's a time-pressured exam, and good time management and efficient use of the BNF are kind of the key to success. If you don't know the question, it's better off just to flag it and just move on. There's no negative marking, so it's multiple choice. So if you don't know something, it's better just to fill it in if you really don't know and just guess. You've got a 20% chance of getting it right. The good resources for the PSA are kind of past papers on their website, which are probably the closest kind of thing that I used anyway to what the real life exam was like. But I know a few people and myself that used the QuesMed ones before as well, and they were really good. And obviously come to our sessions as well. So it's a computer-based exam, so make sure you activate your account beforehand. Your med school should kind of make you aware of all the stuff you need to do beforehand anyway, and make sure you have your password handy for the day. Try and arrive early so you can make sure that you log in. Obviously, computer problems, stress on the day, not ideal. So try and arrive kind of 5-10 minutes early just to make sure that you've got logged in and set up. And remember, you'll need your ID and a pen for making the notes, especially in the calculation section. There's no pass mark. Every paper's reviewed afterwards, but it's usually kind of in the region of about 65%. So this is just a run through of all of the different sections of the PSA. So I think we've covered all of the other ones in our last few sessions, which will be on our website, and the last two that we're covering are calculations and data interpretation today. So a few learning objectives, so we'll go through them now and then we'll circle back to them at the end as well to kind of recap what we should have learned. So with the calculation section, we're going to go through the basic drug dosage calculations, fluids and kind of peds fluid calculations, infusion rates, and then opiate prescribing as well, which are the kind of big hallmarks of what you'll need to know. And then for data interpretation, Yi's going to go through some stuff on insulin, some blood work, bits and bobs, gentamicin and how to dose it and understanding all of that. INR with warfarin and bits and bobs, and how to use medicines complete to guide the medication adjustment. So let's start off with some calculations. If you haven't already got a pen, I'd suggest that you get a pen and just a piece of paper and a calculator as well before we start. So the calculation section of the PSA is 8 questions. So it's 2 marks per question. So it's one of the shorter sections, but anywhere that you can pick up marks is for the best. It's probably one of the more straightforward sections as well, so kind of making sure that you've got that under your wing would be a good thing. It's usually questions on fluids and drug calculations, but commonly tested things that you kind of need to know are pediatric fluids, infusion rates, and particularly they really like testing opiate breakthrough dosages, so just making sure that you kind of know bits and bobs around that. Nice. So we'll get straight into it. We'll do some questions and then we'll go straight to the answer and then we'll explain them. Obviously, we've only got a certain amount of time this morning and we don't want to take too much out of your time on a Saturday morning. So we'll give you about half a minute, depending on how hard the question is, and then we'll go through it. So don't worry if you don't get it in time. We're going to go through the explanation anyway. Nice. So our first question is, a 70-kilo patient is being prescribed amlodipine, which is a CCB for hypertension. The prescribing instructions state to administer amlodipine at 0.5 milligrams per kilogram once daily. What is the correct dose of amlodipine to be administered to the patient? So we'll give you about half a minute to work this one out.
And for anyone else that wants to interact, I'll be also doing a short poll as well, which I'm just trying to get ready.
Nice. So, shall we go to the answer? Great. So the answer is 35 milligrams. So we'll go through the explanation. So the dose of amlodipine is prescribed based on the person's weight. So in this case, it's 0.5 milligrams per kilogram. So all you need to do, I don't know why that's duplicated, but all you need to do is times their weight by kind of what the prescription needs per kilogram. So in this case, 0.5 times 70 is 35. So that was a nice straightforward one to start off with. So this one is the next one. It's about paediatric fluid calculation. So we'll give you a little bit longer to work this one out. So a 10-year-old child weighing 30 kilos is admitted to the hospital. You assess their fluid status and you find them to be euvolemic. So using the 4-2-1 rule, which is just below the question, please calculate their total daily fluid requirement. So how much is needed in the first 24 hours of their admission. We'll give you about a minute to sort this one out. And I'll try and sort out a poll as well. Nice. So shall we go over to the answer? So the answer was C. If you had enough time to work it out, congrats if you got the right answer. And we'll go through the explanation now. So the 4-2-1 rule is a formula for calculating IV fluid requirements for children based on their weight. It's quite commonly tested in PSA questions, so it's a nice thing to be able to remember. It's fairly easy to remember. So the calculation is for the first 10 kilos of a child's body weight. It's 4 mils per kilogram per hour. For the next 10 kilograms, it's 2 mils, and then for the remaining, it's 1 per kilogram afterwards. So you can see here that we've used the 4-2-1 rule. So we've got a total of 70 mils per hour that the child needs, and then you times that by 24 hours for the hours in the day, and then you get a total of 1,680 mils as their daily requirement.
I guess we just got a question from the chat and just seeing who it's from. Oh, Megan. So would we be given this formula in the exam for this type of question, or do we need to memorize it? Is it in the BNF or Medicine's Complete? I would.
So I think
Sorry,
on.
Captain. Yeah. I would say that generally sometimes they do give you the formula, but there are also questions that sometimes they do not give it. So it's a hit or miss in sort of this thing. However, I think fluid pediatric fluid requirements are something worth to learn and keep in your mind, because as you get closer to finals, it's one of those things that you're expected to know off by heart, unless it's a neonatal fluid, which is entirely different.
Yep. So, it's also worth mentioning that if a child is dehydrated, so in this case they were euvolemic, generally, unless the question tells you otherwise, you'd assume that they're kind of got a 10% deficit. So that means that you calculate the total 24-hour fluid requirements. You can use a different formula. So to calculate the fluid deficit in a dehydrated patient, you'd calculate the percentage that they're dehydrated. So in this case, 10%. So 10 times their weight and then times that by 10. So that gives you the number of millilitres that they need to have added on for the 24-hour period. So that means that their total fluid requirement is the maintenance fluids plus their fluid deficit that you've worked out. So if the child was dehydrated, in this case it would be 4,680 mils that they'd need during the day. Generally, the PSA usually just assumes that they're euvolemic, and it would be maintenance fluids, but occasionally there are a few practice questions that I did that kind of assumed that they were 10% dehydrated. So it's just something to mention.
Catherine, I think we just got another question for your to see. Nene has said that isn't there the 150-20 ml rule as well for pediatric fluids?
Oh, I haven't heard of that one. Have you heard of that one, you?
Yes, so 150 and 20 is usually the calculation that you need to take into account when prescribing maintenance fluids. As well, those ratios may change depending on the age of the child as well. So if you're dealing with a neonate, which is any infant up to the age of 28 days, they will give you the values because that's some ultra specialist stuff that you wouldn't expect to know. If it's a resuscitation fluid as well, like we've mentioned here, we also have to take that into account, and that's a different sort of thing. So the 150-20 ml rule, it's some sort of general maintenance fluid on a 24-hour daily basis for anyone that's not a neonate and above.
Nice. I hope that answers your question. So we'll move on to the next question, if that's all of the questions today. So the next question is, a 70-kilo patient is prescribed vancomycin for a severe infection. The dosing guideline for vancomycin recommends an initial loading dose of 25 milligrams per kilogram, followed by 15 milligrams per kilogram every 12 hours, and that is maintenance dose. It's just worth mentioning that the patient has normal renal function. What is the total amount of vancomycin the patient will receive in the first 24 hours? So that includes the loading and the maintenance doses. I'll give you about a minute to sort this one out. Nice, so that's about a minute now. Shall we reveal the answer? Nice, so the right answer was D, and then we'll pop through the explanation now. So in this case, the loading dose you need to work out, and then you need to work out 2 of the maintenance doses because they're given 12 hours apart. So assuming that the loading dose is given and then the maintenance dose is immediately given after that, then there's another maintenance dose within that 24-hour period. So first of all, we'll work out the loading dose, which is 25 times 70. So that's a total of 1,750. So that's your loading dose move that aside for the moment. And then you've got two maintenance doses to kind of work out. So the maintenance dose was 15 milligrams per kilogram, so 15 times 70, which is 1050. And then you times that by 2 to get 2100. So that's the total maintenance dose that they'll get in 24 hours. And then you add on that loading dose to get 3850. Any questions about that one at all?
Sounds like everyone chose D, so not that much, but yeah, let's go.
Great, excellent. So we'll move on. So a patient is receiving furosemide IV for acute pulmonary edema. The IV dose is 40 milligrams. The doctor decides to switch the patient to oral furosemide. The recommended conversion is that oral furosemide is absorbed at 50% bioavailability compared to the IV dose. What is the equivalent oral dose of furosemide for this patient? I'll give you about half a minute for this one. Nice. So if we go through the answers now. So the correct dose was C, 80 milligrams. And then we'll go through the explanation. So the patient's currently receiving 40 milligrams IV. So if we're switching it to oral, it has 50% of the effect of an IV dose, which is what's meant by the 50% bioavailability. So for it to have the same effect, it means that we have to times the IV dose by 2 to get the same effect orally. So in this case, it'd be 40 times 2, which is 80. Any questions about that one at all? Bioavailability is something that PSA does quite like to test. And once you get your head around it, it's one of the easier questions. Great. So if there's no questions about that one, we can move on to our fifth and final question of the calculation section. So a 70-year-old patient with advanced cancer is prescribed a continuous morphine sulfate infusion at a rate of 30 milligrams per hour for pain management. The patient reports experiencing breakthrough pain, and the guidelines recommend that breakthrough doses should be 1/6 of the total daily dose of the regular opioid regimen. Which dose of morphine sulfate should be prescribed for each breakthrough pain episode? So I'll give you about 45 seconds to work this one out. Nice. So if we go through the answer, if we reveal the answer. So the correct answer was D, 120 milligrams. So if we go to the explanation slide, opioid prescribing is really commonly tested in the PSA, but also in your finals as well. So I think it's an important thing to try and remember that usually the breakthrough doses would be about 1/6 of kind of the person's whole day dose. So we'll go through this one first, and then we'll have a bit of a chat about that afterwards. So in this question, the first thing you need to do is calculate the person's total daily dose of morphine that they're getting. So they're getting a continuous infusion of 30 milligrams each hour. So first of all, if you calculate the whole daily dose, which is 30 times 24, you get a total daily dose of 720 milligrams. And then afterwards, we need to calculate the breakthrough dose from that. So the question has been quite nice to you and said that the breakthrough dose is 1/6 of the total daily dose. So if you take your 720 that you've got, divide it by 6, and then you get 120 milligrams as that person's breakthrough pain dose. It's worth mentioning, if you're on the wards, a normal ward, and you work out that somebody's breakthrough dose would be 120 milligrams, it would definitely be worth double, triple checking that, because this is a palliative care question. So that would be a really, really high dose of morphine to give your regular average Joe. So in palliative care questions, if you kind of get an answer like that, that would probably be reasonable. But if it's just kind of saying, oh, this person's on a ward, you might just want to recheck your answer. So yeah, any questions about that one at all? And if not, we'll go on to data interpretation with you.
Right, so I think if you have any questions, just do take your time to answer it in the chat. And we'll just give you a bit of a break. And while doing this break, it'd be really great if you guys are able to open the BNF or Medicines Complete, whichever you guys are more comfortable in using to help answer these questions for data interpretation. So in data interpretation, it's 6 questions in total for the exam, each question worth 2 marks, which will give a grand total of 12 marks. In these questions, you'll be given a set of data in aspects of a clinical scenario that you yourself will have to take the lead and make the decision based on the clinical situation that you're given and the investigation results that they choose to provide to you. Now, in these scenarios, you as the doctor will have to do any of the following decisions. You can choose to stop a drug that they are currently on. You can increase a dose of a drug. You can decrease a dose of a drug. You can even start a new drug if you wanted to. Prescribe another drug together with the existing ones to improve treatment or efficacy. Or in some instances, you absolutely don't have to do nothing at all. This just basically tests your judgment and your clinical knowledge to see what's the most appropriate management step next. And the order of these questions do not go from easy to hard. They're all scattered all over the place. So you can get an easy one at the start and a hard one over the next. So the difficulty varies with this. So once everyone is all right with their BNF and medicines complete, then we can get started with looking at the questions and answers with the explanation. In these questions, I think I will introduce the STEM, and everyone will just have a chance to read through it at their own pace and try to answer the question. This would really test what information you want to dissect as the most important to help you find the correct part of the BNF or medicines complete to try to find the correct information to solve the question. So we will start with the very first question at this moment. And you have 3 minutes to complete it. think we just about reached the mark to review the answers once everyone has a chance to have a look. So the answer for this question is answer B, add atorvastatin 20 milligrams once a day. Now let's dissect this question a little bit. You want to see the most important points on what could determine treatment. So we have a 68-year-old woman coming to a GP for follow-up for some blood results. The most important thing to know is why she came in. She has no symptoms since her last appointment, so there is nothing acutely unwell going on, which is good. One thing to note is sometimes you have to look at the past medical history and the social history. So she's quite sedentary, active smoking history, quite a significant family history for angina as well. So has a lot of risk factors in her lifestyle, would say. And when you go to investigations, the GP has kindly done the following things just to explore around that. Most notably out of all of this is her QRIS score. And with the QRIS score, the QRIS is basically a scoring system that we use to assess the likelihood of someone going to suffer a cardiovascular disease or incident within the next 5 to 10 years. And usually we want to start medication if that score is above 10%. So if you're not so sure what to do with that, you can always go to the treatment summaries. And in this particular section, you want to find the cardiovascular disease risk assessment. And since she's not having symptoms at all, we can say that she has the potential to have angina, but she's not having it yet. So we need to focus on primary prevention to prevent all of this from happening in the first place as much as possible, since her bloods are also showing that she's abnormal for lipids. Overall, if you will go to lipid lowering therapy in the primary prevention part of it, you would see that they will recommend lipid lowering therapy. And with that, you will go down to find atorvastatin, which is what they usually recommend over there to prevent a CVD due to a high QRS2 score. And since this is the first time we're going to give her this medication since she's not having it before, we are just going to start with the lowest dose of 20 milligrams once a day. Yep. So that is quite a lot to dissect for one of the very first questions, but that's the amount of effort you can get for some of the straightforward questions in a section like this. So if everyone's happy with that, we can move on to the next question and have a look at it. And again, I'm going to give you guys about 2 to 3 minutes to have a little read about this question and see what you guys think. So for what Emily, I think I'm just seeing a question right now, does not have hypercholesterolemia, so 10 milligrams once a day. That 10 milligrams once a day is usually quite a small dose, first of all. We usually want to start 20 based on your Q risk assessment as well. So that's also essential finals knowledge you want to start. Secondly, 10 milligrams, it's usually sometimes linked with a early familial hypercholesterolemia as well. So yeah, there's a combination of factors why we don't really usually start with 10 milligrams. It's mostly due to the fact that that's too small of a dose. We usually like to start 20 at bare minimum, unless there's contraindications, that is. Right, yeah, getting the answers. All right, so that is time for everyone. Let's go through the answers. And there was an error in the text on the previous one that C was meant to say 100 micrograms, so I do apologize for that. But everyone still got most of the correct answer here, and that is C, levothyroxine 100 micrograms once a day. So, to dissect this question, we have a 26-year-old man who has come to his GP again. He complains of lack of energy and intolerance to cold, and he is known to have hypothyroidism. So, that will get you thinking, these symptoms do sound like his hypothyroidism is acting up again. And he's already having a levothyroxine therapy to try to solve that in the past. So what the GP has done is he has done some thyroid function tests kindly to see if the levothyroxine therapy is indeed working at the moment. And it turns out it shows a pattern that he is deficient in his thyroid hormone as well. So we would need to actually increase his levothyroxine dose. Now, this will involve you looking into the BNF in levothyroxine just to see what the drug is, and he is having primary hypothyroidism. Now, it's worth to note that he is a young man as well, not elderly, which has a different entire rule to it. So it's important to look at age. But just looking into adults, we can see that they usually recommend an increase of 25 to 50 micrograms when you want to start the dose. And that is the recommended safe level for it. So in the PSA, you want to play it safe when you want to increase the dose. So even though you can increase it to 125, which was my mistake in the other one, I do apologize. It is generally safer to start increasing it slower. So increasing it by 25 micrograms is the more correct answer, which is why 100 micrograms once a day is the correct answer for this. Um, and just for your information, in case you do ask us for finals as well, when you do want to change your levothyroxine dose, you will want to repeat thyroid function tests in 4 to 6 weeks to make sure that the thyroid control has been successful. So we do have a really long dot questions. I think we will give you an extra minute, so about 3 to 4 minutes this time, to try to dissect all of this information. All right, and that is the time to spend for these questions. Do not worry if you don't manage to complete it. We'll go through the answers anyway. So, from what you should get from this, you should have get choice number D. Excuse me, which is to start 30 milliliters of calcium gluconate, 10% over 5 minutes. Now, there are a few things to dissect and to point out from this question. So, we have a 50-year-old gentleman being admitted to gastroenterology due to progressive ascites that was noted on the CTAP and his symptoms as well. He has also been found to have palpitation in his chest since his admission to the gastroenterology ward, which is quite concerning as well. And we can confirm that important history is that he has liver cirrhosis secondary to alcohol, and he also has essential tremors, which is another thing to note to cover as to why. Other things to note is that we started him on spironolactone in the ward, and again, for the essential tremors, he has propranolol as well. Now, we have a lot of these investigative findings, but the things to note are the ECG findings, where this says that there are no narrow T waves, a T wave amplitude that is greater than 5 millimeters, which means it's tall, which can kind of give you a hint that it's tall and tented. The QRS complex is also quite prolonged as well, and so is the PR interval. Then we look at the VBG, and we've shown that the abnormal result is that potassium is quite raised, and not only is raised, it's significantly raised as well. And just linking all of this thing, he has ascites secondary to liver cirrhosis, which the best diuretic to treat this would be spironolactone in this case. But as you know, spironolactone can cause hypokalemia, and this is the situation that we're dealing with, and this is why he's having the new onset heart palpitations. So, from remembering your value of 6.6, this is classified as a severe hyperkalemia, which is noted down in your treatment summary when you search up hyperkalemia. Hyperkalemia in the treatment summary has actually listed down, albeit in a giant wall of text, the hierarchy of treatment that you want to use. When we will go back to the answers over here, calcium gluconate is the best first line, and we will go through all the other medications that we can do next after that. The second part, adding another diuretic like furosemide wouldn't solve this issue, as actually he's already been given the diuretic. We're just going to give him way more diuretic, and he's going to wear it out more. He's going to get even more dehydrated, which add another problem to the issue. Adding salbutamol is not a good idea, and that is why I've highlighted propranolol and essential tremors, because salbutamol is a beta antagonist as well, agonist, and propranolol is a beta blocker as well, so they just kind of counteract with each other, and it would just do nothing to the treatment at all. Act Rapid and 10% dextrose is appropriate to treat for hyperkalemia, but it's not the very first thing we do. The reason why calcium gluconate is the very first thing is the priority is to stabilize the myocardium, aka stop the heart from going into an arrhythmia, which is what calcium gluconate is used for. Then lastly, sodium zirconium, or maybe you will learn in your textbook instead as calcium resonium. Either those two can be used to treat hyperkalemia, but they have a very slow onset in acting to reduce it. They remove potassium through your feces, so this would take quite a few hours to do. So it's not the best thing to give if we have a very acute severe hyperkalemia, like in this case. And for all of you folks, for reference to prepare for finals, I've prepared a little screenshot of what to do and when to panic and not to panic when you see a hyperkalemia, as long as a treatment hierarchy, just to, in summary, as a quick reminder and refresher for finals in the future as well. If there's any questions, we can go through the chat, but I'm just going to be moving to the very next question that we have over here. And again, you have around 2-3 minutes for this one, and we'll see what everyone gets. All right, that is your time to answer this question. And the answer for this would be D, gentamicin 420 milligrams IV over a 36-hour period. Now, gentamicin dosing is one of those very tricky things that you have to learn for the PSA, but it's something that is going to be kept to is going to be something that is going to keep appearing in your practice papers, and it is very clearly pointed out in your syllabus as a core thing to need to know for the PSA. So you need to get as very comfortable with it as much as possible with it, sadly. And as well as when you guys become future F1s, when you join us in the wards, this is something you have to do on a daily basis as well, as it is quite a common strong antibiotic that we usually give. We need to first start as to some information here. We are treating a urosepsis, so secondary to its UTI. She weighs 60 kilograms as gentamicin dosing requires your weight, so that is something important to highlight. Another thing we need to make sure is that we need to see what sort of dose have we started her on the gentamicin. She's having 420 milligrams at the moment, and that is a good thing to point out because if we do need to increase the dose, we want to make sure we're increasing it at a safe limit. As one important thing to note is that gentamicin, the max dose you want to give is 560 milligrams per once a day, no matter what. That's your maximum dose. If you calculate a number higher than 560, you still have to give 560 max. Then we need to check her renal function. Particularly her urinase, urea, creatinine, and her EGFR. And her urinary function is fine in this case, but if it's not fine, then we need to think of another way to calculate the dose. Normally, assuming everything is fine, like in this case, your dose will be calculated on the basis of 7 milligrams per kilogram. If her renal function was quite terrible, then we need to reduce it to 3 milligrams per kilogram. And that is because we need to be safe with this drug, as gentamicin is primarily excreted through your kidneys, and if this continues to accumulate a lot in the kidneys and through the bloodstream, it can increase the risk of nephrotoxicity and more commonly ototoxicity. So you will get hearing problems and tinnitus with it as well. So we've taken the gentamicin level like we did in the question over here, and we've seen that it was 5.0, and it's good to notice the time that was taken because we usually want to take it between the 6 and 12-hour period from when we first start the dose. So we consider in that range, and it's good, it's 5.0. Then we need to look in the chart. Okay, they've given 5.0, so we mark 5.0 on the y-axis. Then we want to see the sampling time, so the time that was taken from the dose given at 11. Once those points intersect, they intersect within the 36-hour region of this nomogram. So therefore, the best thing that we need to do is increase the interval of the dose to 36 hourly while not changing the dose. And to go into more detail about gentamicin, in the exam, there are 2 ways that can be used to monitor gentamicin dosing that they could ask you. They could ask you to use the gentamicin nomogram or the graph that we've just used in this question, which is a more common example. Or they could be a bit mean and say that they could use peak and trough values instead. Now, you can find these sorts of explanations within the gentamicin page on the BNF when you search a drug under monitoring requirements. However, to really summarize it into detail, and this is what has helped me prepare for it as well, peak value basically means, does the dose need to change? If it's too high, we need to reduce the dose. If trough basically means, does the time between each dose need to extend or stay the same? If the trough level is too high, you need to increase the interval. So that could increase it to 36 or even 48 hours, depending on what it is. And one thing I've noted in the therapeutic drug monitoring page for your future reference, because it did appear in a previous PSA sitting, was gentamicin prescribing and endocarditis, because it has its own rules that are different to every other condition, which is why I've highlighted earlier on that we need to know why we're given gentamicin in the first place. Right, I'm just seeing if there's any questions. Wei Jie Tiam, okay. Where did you get the info on dosing and renal impairment being 3 milligrams per kilogram? So you can find that in the renal impairment part of your gentamicin page. However, this is also something that could be used in finals, and if you have it in the back of your mind as well to prepare for finals, that could come in handy as well. But you can generally, in case you forget due to the pressure of the exam, you can look into the renal impairment part of the BNF under gentamicin to find that. Anything you want to add to that, Catherine?
No, I don't think so. I think, yeah, the BNF's your best friend is 100% the answer. Yeah.
Awesome. Right. Very nice questions, everyone. And before we move on to the next one, I think because gentamicin is not the only baddie that you have to deal with to monitor your antibiotics, unfortunately. Something that you probably need to have a worth to read is vancomycin and teicoplanin, because those antibiotics are quite commonly used in the wards as well, albeit they're the stronger versions that we don't tend to use for most infections, but they also require monitoring. So it is a good shout to have a look in the monitoring requirements as well as the treatment summary pages, just to get an idea of how they should be monitored, just in case you need to look into it if a question asks for teicoplanin or vancomycin. Now we have another very long question, and this would take quite some time, around 3 minutes, and then we will take it from there. All right, that is time, everyone, for this question. Time flies really fast for it. And the answer that we would like to see is D. IV N-acetylcysteine, 9,000 milligrams over 1 hour period in 200 milliliters of 0.9% sodium chloride. Now, this is quite an unfortunate thing that we tend to see in A&E from time to time. And for those of you who have yet to do your ED placements, expect to see this at least once, of an example of an overdose of a particular medication. So this 20-year-old university student actually came in at 3 a.m. and they came in because their roommate found them feeling nauseous, drowsy, and just feeling quite unwell, sort of. Being a good friend, he helped him to go into the hospital emergency department, where he told us that he ingested about 500 milligrams of paracetamol tablets in one single swallow. And that is very important to notice, because you need to know the mechanism of the overdose and how much he has taken. You also need to know when this has been taken. So this was been taken around 8 p.m. the previous day, before they found him on 3 a.m. this morning as well. Ideally, you want to get other information from the patient, such as his weight and has he taken anything else on top of the paracetamol. Thankfully, this is a bit more straightforward. He's only taken the paracetamol. So when we look at the investigations that they've given us, they've given us quite a range of things, but the most important things that strike to us is the paracetamol concentration, because we're dealing with a paracetamol overdose, and an abnormal result of random glucose at 10, which is a bit high. So you would want to go into the poisoning section of the BNF or your medicines complete. Will contain all your emergency treatment needed for any overdose of any substance that's listed on there. Then you just need to go down the paracetamol poisoning section. So first we need to get some numbers down. We need to calculate how much paracetamol he has taken overall. So 30 tablets times 500 milligrams is 15,000 milligrams of paracetamol circulating in his body total. Blimey. Then we need to calculate the time between the time of the overdose and the time that he got into the emergency department, and that is a 7-hour period. So why do we need to bother with all of this? Because it does help us categorize what type of overdose he has taken. I'm just going to explain it right now, but if you guys forget in the exam, the explanation is indeed in the treatment summary of that page in the BNF. But essentially, an acute overdose is an ingestion of a potentially toxic dose of paracetamol in an hour or less. Basically, this definition means taking a dangerous amount in one or multiple goes within that same 1 hour period. This intention could be linked to self-harm. A staggered overdose is an ingestion of a potentially toxic dose of paracetamol over more than 1 hour. So if it were the case in this example, because the patient had taken it all in one swallow, we can assume that it's an acute overdose because it's all within that same 1 hour period, less than an hour. So it categorizes in that. Had it been a staggered overdose, if we use the same number of 30 tablets he's taken total, as an example, the patient may take 4 in the first hour, and then 10 in the next hour, and then 8 within the next 3 hours, and then maybe another 8 in the last 2 hours before he's come into the emergency department. So knowing how much he's taken and over what time period is very important to categorize, because that will affect the treatment and our treatment regime later on. So let's look at the BNF's criteria for the acute overdose now that we've have established that it is an acute overdose. He is definitely not doing so good as he fits the criteria of ingesting more than the safe amount in one go, which is 4,500 milligrams. Pretty much his body is toast at this point. So that leaves us the question of what we can do for him. Based on the guidelines over here, we sadly cannot consider activated charcoal as he didn't present within a 1 hour period from his ingestion of a large dose of paracetamol. Had he presented about 9 p.m. the previous day, this would be the best choice as it goes in and absorbs all of the medication while it hasn't completely digested before it absorbs into the GI tracts. We will have to move on to N-acetylcysteine, therefore, and note that N-acetylcysteine can be also considered in hepatotoxicity, and those who present with 8 hours of ingestion of more than 150 milligrams per kilogram of paracetamol, if there is an ongoing delay of 8 hours or more in obtaining the paracetamol concentration after the dose. So for the PSA the exam, they will probably give you a paracetamol graph like this, or you probably need to see it in the BNF itself. Now these graphs, whether they choose to give you or not, or you have to find in the BNF or Medicines Complete, is calibrated for the standard 21-hour regime only. So anything on the paracetamol page that says 12-hour regime or 14-hour regime, do not use that at all for the exam. We've taken his paracetamol concentration is 95, and the time frame 7 hours. So as we were to graph that onto the graph, this does lie above the treatment line, which means he does need N-acetylcysteine. And from the clinical scenario, we can infer that we are giving the very first dose as nothing has been given since then, or we weren't told. So note that his weight is 60 kilograms, and 60 kilograms times 150 milligrams will equal 9,000 milligrams over an hour period. Now, the reason why I've highlighted the glucose is because you have a choice of putting the N-acetylcysteine in either dextrose or saline. And since for some reason he's hyperglycemic, we don't really want to give him any more glucose, as that would drive it even more crazy. So your sodium chloride would be a better bet in this bit. And do note that it's important to know if we're given the first dose or the second dose, as in another setting that I've been told, they were told to give the second part of the treatment, which is listed over there. So just be a bit careful for that bit. This is one of your examples of very long questions. So yeah, apologies for the very long-winded explanations of it as well. We've gone to something a bit shorter right now, 2 minutes time, starting right now to answer this question over here. So while everyone is doing this question, I'll just set up a poll. And for Shirin Man, how did you choose between a 12-hour SNAP regimen and a 21-hour regimen? So for this purpose of the exam and in standard practice, we usually go with the 21-hour regimen, unless they specifically tell you to go for the 12-hour SNAP. The 12-hour SNAP regimen is usually a specialist sort of regimen, so that's not something we'd be tested at this stage. So always use a 21-hour regimen. And your paracetamol nomogram is also 21 hours, so that's your big clue as well. All right. If everyone's happy with this one, we will review the answer as E for this case where we're looking at INR. So this question was inspired by something I actually had to see within like the first 2 months of my F1. But this in this particular scenario, this lady has unfortunately had a usual picture of bleeding or hemorrhage. In this case, a hemothorax. Unfortunately, the woman was also on warfarin, as this was and this is the cause of the major bleed, and the warfarin already given has been stopped. We need to also try to see how we're going to stop this further. So that's why we highlighted all this information over here. Vitamin K, or sometimes I like to say phytomenadione, has already been given. So the next best step would be for dry prothrombin complex concentrate, or PTCC. TXA can be given, but doesn't really solve the underlying cause of hemorrhage. Um, Idarucizumab is a monoclonal antibody only given to reverse one type of DOAC only, which is dabigatran. Fresh frozen plasma and cryoprecipitate can give intrinsic clotting factors, but it is not really the best choice to solve and really stop this underlying hemorrhage. So when you go under your oral anticoagulant page, you would go under the hemorrhage page over here, which would highlight your warfarin treatment, how to stop warfarin. From all the information we found with the INR and everything, INR was quite high, and this is a major bleed. So therefore, you want to focus on the top part, which says to give vitamin K and PTCC as well. And this is something that you need to know for finals as well. But in the purpose of this exam, you just go to this page and it says everything just in case you forget. And that's just the example of the page to show you about what to prescribe if needed for another type of question for dry prothrombin complex. And this page over here just basically highlights a summary of hierarchy from what we've seen from the BNF to see what sort of treatment we need to give as well, as this theme does pop up in your finals as well. Now we move on to another question, and we give about 1 to 2 minutes for this one. All right, and that is time for this question. Now let's have a look at the answer. The answer would be A, increase the pre-evening dose Novorapid by 2 units. So just to quickly highlight the important bits, it's a 13-year-old girl just trying to see how her glucose control is for her type 1 diabetes. We have to see what type of insulin she takes and the schedule of it, which is why I highlight her drug history. And we want to see her glucose control, which is not doing too well, but not horrible at this stage. And most importantly, you'll be given a table exactly like this in the exam itself to have you look at the tracking of her glucose whenever she has a meal before or before she goes to bed. Now, just to summarize how we solve this, each capillary blood glucose level is taken before each event. So before her breakfast, before her lunch, before dinner, and before she goes to sleep. Insulin is pretty much only taken after eating and the basal dose before she goes to sleep. So the aim of this monitoring is to assess if the previous dose of insulin before she takes her blood glucose for the next event has done its job to keep the glucose in its range so far. If at a particular time, like in this case, that it's out of range, that means the previous dose before that is not enough. Therefore, in this example, since the pre-bedtime glucose is high, it means the insulin taken after dinner is not enough. Therefore, as a general rule, which annoyingly is not really stated very clearly in your BNF or Medicines Complete, but through practicing a lot of questions, you find that they like to advocate for a safe increase of insulin by 2 units. Hence why the best answer would be A in this scenario. Right, so the next question over here is about HRT, and we guys give you a shot at this question and see how you guys feel about it. And that is time for this question. So hopefully you guys got the answer E, to ignore all the remaining pills in her pack, to start an entirely new pack immediately and abstain from sexual intercourse and use barrier contraception for 7 days. Now, highlighting important information, she's on microgynon 30, which is a form of COCP. She is just about to finish her third month pack, and that's something we need to notice about how far she's gone through her current contraception. The scenario that we faced is that she's forgotten to take her 3 pills within the third roll of her medication. So, like we confirmed previously, she's about to finish this month's pack. She's been sexually active with multiple partners as well, so we need to assess the safety with her contraceptive use as well. And we also need to know how long she's had these unsafe coitus as well, because she's flew back 24 hours ago, so that's important to know. The best way to solve these questions, because it's quite hard to see in the BNF or Medicines Complete, is to actually study a table like this. This table is provided currently by the Faculty of Sexual Reproduction and Healthcare, or the FSRH here in the UK. And it's probably one of the best tables I've ever seen that really summarizes all these points as well. So whenever you have anything like this from unsafe sex, pregnancy test should be done within 21 days of unprotected sex as well. And if you had a read through this table, you can start to work out about and start to learn about when it's safe to start contraception, when do you need to start emergency contraception, when do you have to not do anything at all, or when you could just ignore the rest of the pills, like in this case, and just continue on earlier on with the next following packs. And that's something really important to notice as well. One important thing to note as well is to just have a read through on the treatment summaries for emergency contraception, hormonal contraceptives, and non-hormonal contraceptives as well, as those themes can unexpectedly sometimes turn up in the actual exam. So it is good to have a read around those topics as well as it does help to read around for your finals exams as well. And good news, everyone, that is the very last questions I have for my topic. It is quite a long time, but the data interpretation side, it is one of the longer sets of questions that you have to deal with such a short amount of time in the exam.
Nice. So, if we just go over the learning objectives again. So we've covered all of that in the calculation section and a lot of all of that in the data interpretation section. I appreciate that it's a lot to take in, but hopefully it's been a good whistle stop tour of all of those things that we hope to cover at the start of the session. So this is just, again, what we've covered. So calculation skills and data interpretation. And just to kind of remember that it does all link in with all of the stuff that you'd really be revising for finals anyway. So it kind of stretches across the whole of the curriculum. But most of the stuff that you will be asked, especially in the calculation section, you won't really need to have any knowledge of kind of final stuff necessarily. It should all be there either in the BNF or on paper for you to be able to work out. So these are a few of the resources that we all used in the committee when we were kind of working towards our PSA. So definitely the online resources for the PSA that they've made themselves 100%, I think anyway, personally, is the best thing to use in the run up to the PSA, especially the mock papers. There's a few other things. So BPS e-learning, they've got 9 free modules for you to be able to do, and then you can purchase some mock papers. The Geeky Medics PSA question bank is really worth investing in my opinion. It's got a wide variety of questions and it's not that expensive either. Same goes with Pass Medicine. Alongside your finals kind of questions, it's useful. And then the script modules as well that I think lots of universities are pushing now. They're quite useful as well, just to kind of refresh your memory before you start F1, especially in prescribing. But they can be useful in the run up to the PSA as well. But yeah, the BNF and Medicines Complete are 100% your best friend in the PSA. So just practice, get familiar with the sections of the BNF that you're going to need to know.
So this is just our feedback form, which we aim to appreciate your feedback and our appreciation for everyone to attend our sessions. Glad everyone's enjoyed the hard work we've put in so far, but we would like to improve anything that we've presented just so that it's better presented for the next section, or maybe even some better suggestions of how we could make this more interactive or perform better in the future. Everyone's feedback, no matter how big or small, is greatly appreciated, and it will contribute greatly for our own research as well as we strive to improve a small part of medical education on our side as well. And
so that's it from us this morning. This is the end of our PSA series for the moment. Obviously, they'll be available as recordings on our website. The next time that we'll be running sessions will be for our final series. We're hoping to start them in March, but obviously keep an eye on our social media, and we'll be publishing the dates a bit sooner to the time. If anybody's got any questions, just pop them in the chat and we're happy to answer them.
yeah, I think there were a couple, Catherine, so let's just have a look. Let's see. So Eleanor, Harry, good news, we've just finished as well, so that answered your question. Yeah, sorry, it took quite a bit. The data interpretation was quite a lengthy part. Amna Tanvir. Sorry, could you just go back to the flow chart if that's okay? Of course. I think he or she is referring to the contraception chart. So this is the chart that you can use to help learn. As I said, it is one of the best summarized charts I've actually seen out there on the online world as well. But if you want to read it in a bit more detail, you can always go on to the FSRH's website, where you can find not only the chart, but some more detailed explanations on guidelines that are up to date in the UK as well.
Yeah, they're really user friendly as well on the website. You can kind of open up leaflets and things like that of the guidelines, and I've found them really user friendly before.
Let's go through. Sophie Cruz. How long do we get for each question again? So you want to start with your section, Catherine?
Let's have a look. So for the calculation section, it's so you get an unlimited amount of time really for each section, but you should be aiming for a certain number of minutes. So I'll just grab up the first bit. I'm not lying to you. So for the calculation section, you've got 8 questions and you've got 2 marks per question. So you should aim for roughly about 10 minutes. And then for the data interpretation section, there are 6 questions with 2 marks each. So you should roughly be aiming for about 6 minutes. But when you've got a harder question in there, they can take a little bit longer. So a little bit of leeway. Yeah.
Right. Okay, yeah. Answered Megan Hodgson. Feedback form for Thursday. I think if you scan the QR code, but fill in the form for the previous section, but fill in another form for our section, I think that shouldn't be a problem as well. But we do appreciate your feedback, and thank you for letting us know. We'll pass on your good thoughts and sayings to the previous people who've done this teaching.
Shall we pop up
Uh,
the QR code again just so that people can scan it?
yes. I think I maybe have flipped that too fast. There we go. Nina Khan has come back to say that just on the gentamicin question real quick. The renal impairment section doesn't mention reducing the dose from 7 milligrams to 3 kilograms. Ooh.
Let's just have a look. I'll have a look on my BNF.
Right, sure.
Was it in a separate section, you?
It could be actually, because it does mention a BNF, maybe not a gentamicin question. Right. Reducing. I'm just having a quick look on my side as well, just in case. Concerned product literature. Okay, so right, they probably changed it because it used to say, but it doesn't say it anymore now. Okay, that's fine. So if they want you to use the 3 milligrams, they probably would have given it to you, to be fair, because it's not on the BNF anymore from last time. So they'll probably give you the renal dose from that. But so the 3 milligrams is something that we actually seen in the wards as well. Not so sure it's the same in your trust, Catherine.
Yeah, it is. But I think in the PSA, if it's not in the BNF anymore, they'd give you that information. You wouldn't be expected to memorise it.
Exactly, yeah. Let's keep going down. James Abston, can you explain what is meant by forgotten to take 3 pills from the third row in the last question? Okay, yeah, I think I made that question a little bit hard just to try to test if people has actually seen a pack of contraception pills. I appreciate it. If you haven't used it, you've probably never seen one before. But essentially, a pack of a COCP is laid out on 4 rows, 4 rows of each of those rows containing 7 pills. So you have the top 3 rows are your active pills, I like to call it. So you take that 7 days, 7 days, 7 days, and then your last pill is your I would call it your dot pills, which is like your uh I don't have the word in my mind. Maybe Catherine can help
Kind
out,
of
but
like
that's essentially
inactive pills.
inactive. Yeah. So that question aims to say that she's completed her first row of active contraception, her second row of active contraception pills, and she's just on her third row of contraception pills. So she hasn't quite touched that part of a cycle where she needs to take the inactive pills from that bit. So if you look on the internet, actually, just to see a picture of a pack of contraceptive pills for 1 month, then you probably see what I mean from that bit. Anything else? Let's see. Oh yeah, I've got lots of people enjoying the session. Like to see that. What day will be recording? Yep, so the QR code is just a feedback form for the questionnaire as well, and the recordings and the slides will be uploaded very shortly. Hopefully within the next week or two at most. It's about teaching, okay. Do you have the correct link? Just wondering, that's all. Having a look. Right, maybe this is the correct link. I'll have a look. Yep, that's the correct link now. So apologies everyone for that. Yeah, and we'll just hang around for another 5 to 10 minutes just to, in case there's any last minute questions if anyone would like to ask. Right, Catherine, maybe you can help for this one. I'm not appearing to upload the correct link for this one.
What's this? Sorry. I can't see the questions, unfortunately.
Are you able to see the chat or?
I can't see the chat, annoyingly.
Right. Okay.
For the feedback form.
It says it's still the teaching evaluation link.
Oh, okay, fine. Just give me 1 second then. The QR code's working on my phone for the feedback form.
Let me. Yeah, I'm trying to put in the link, like the direct URL onto the chat, but they're saying it's still the teaching evaluation link, not the link relevant to the QR code.
Let's have a look. I'll try and put something in the chat, but it might not come through. It won't come through. It won't let me post anything in the chat. Yeah, I've sent it to you. Are you
Yeah,
able
I'm just
to?
having a look. So
Yeah.
it's the exact same thing that I put in the chat over here. So just a bit confused here. question about the session today. I'm just having a look and see. Right, yeah, I don't think we have the correct link from the QR code over here. Let's see. Are we able to distribute it to everyone afterwards from the session? Because I
We
think
should
all the
be able
QR
to put it on
codes.
our story.
Yeah, let's just put it on our Insta story for everyone to have a look. Yeah, because I think all the links we're having are linking to that other feedback form. So
Mm-hmm.
the middle feedback link works. Okay, so if you're able to access that link, then go ahead. But otherwise, we'll put it on our Instagram page as well for that.
Great. So I hope you all enjoyed our session. Me and you probably sign off now, but obviously, if you have any other questions, feel free to message us on social media, and one of us will get back to you. But yeah, hope you have a good rest of your Saturday, guys. Bye.